Hi, I'm Lynn Moffinson from the Elizabeth Glaser Pediatric AIDS Foundation, and this is our pediatric panel, and I'll let you guys introduce yourself.
Hi, my name is Natalia Rachmanin. I'm a professor of pediatrics at George Washington University. I work at Children's National Health System in Washington, D.C., and also I'm a senior technical advisor at Elizabeth Glaser Pediatric AIDS Foundation.
And I'm Rohan Hazra. I am at the Eunice Kennedy Shriver National Institute of Child Health and Human Development, where I am the chief of the Maternal and Pediatric Infectious Disease Branch.
I'm Annette Sohn. I'm the director of the Treat Asia program of AMFAR, the Foundation for AIDS Research in Bangkok, Thailand.
Well, thank you everybody for participating. And I guess what we can start with is probably the biggest news of the meeting, which is the dapivirine ring, the vaginal ring to prevent infection in at-risk women, which showed about a 30% efficacy in prevention, which is very good news. The bad news piece is that in adolescents, it was really pretty ineffective, and adolescents had twice the incidence of HIV infection, and I guess that kind of brings us around to the whole issue of adolescents and the difficulty in dealing with them. And I know, Annette, you're leading a symposium on adolescents. Do you want to give some comments?
Sure. So just to quickly recap the dapivirine ring studies, the two studies, Aspire and the Ring study, enrolled 4,500 women to look at the efficacy of this vaginal ring to prevent HIV acquisition. And in fact, that 18 to 21-year-olds had no effect at all. Just reminds us that we cannot assume these interventions are going to work in adolescents and young adults unless we assess them first. So at the moment, there are 2 million adolescents 10 to 19 years of age living with HIV in the world, about 220,000 new infections a year, which is 600 new young people being infected every day. So this is quite different from people who are much later in life who are becoming infected. And I think we have to remember that they're in a very vulnerable period of life as they're maturing, as they're developing physically, emotionally, psychologically, and that becoming newly infected with HIV will carry with it a chronic disease for their lifetime.
Yeah. Did you want to talk a little bit about the symposium? I know you're going to cover global epidemiology, some thoughts on finding these infected youth, because most of them don't even know they're infected, and linking them to care, and then the whole issue of transition when adolescent becomes adult age and transition in care and the difficulties with that.
Yes. So we're really pleased that the CROI organizers agreed to have this session because I think it's the first time that there's been a dedicated session on these adolescent issues. Actually, Rohan is co-chairing that session. And as you mentioned, there will be talks about why it is that young people have such high-risk behaviors. Sort of the title of that talk is Blame It on the Brain. And I think that that's what people are really trying to understand. Why is it that young people are at such high risk of HIV? What are ways that we can intervene to support them to modify that risk until they get to the point where they're a little more mature, a little saner, and where prevention interventions seem to work better, like was shown in the Ring study, that if you were over 25 years old, protection was much higher, up to 56%, I think, in one of the studies. And so there's clearly something that we as older adults now do not remember or do not understand about what it's like to live life as a teenager, as a young person.
And I think I would just add, too, that, I mean, we know that this is not abnormal behavior on the part of adolescents. This is typical adolescent behavior. As you're saying, we expect a lot of adolescents at that time in their lives to be leaving the home, getting jobs, going off to university. And if they were old and stodgy like me, they wouldn't go off and do things, right? But that we want them to be taking some risks. And I think we have to look at, this is not the first trial that adolescents have done worse than adults. And I think we have to think about how do we harness that risk-taking and energy that adolescents bring in a way to get them to adhere, as opposed to thinking of it as a problem that, oh, if they just weren't adolescents, then everything would be okay.
Yeah. Okay.
And I just want to highlight that the focus is right now on young women, which I think is crucially important.
Yes.
Because we know that among adolescents, young women are even more vulnerable, and a lot of them end up being pregnant, and that affects ultimately our pediatric cascade consideration. but in particular, the mortality among young women is very high. And we really look into means to reach out to them, to find a way to protect them from HIV, but also build a better healthcare system overall around reproductive health and the survival of young women. And HIV might be just an entry door to reach out in the whole spectrum.
And I should probably mention as well a very important point of data that we've been understanding more in the last couple of years, which is that HIV is now the second leading cause of adolescent death globally and the number one cause of adolescent death in Africa. That's a huge change from in the past when young people are in the United States, for example, the number one cause of death are road accidents and so why is it that we're seeing this really high rate of death from HIV in Africa? I think that's something that we all would like to get at the bottom at.
And I think the good news is that research funding and organizations are now beginning to pay attention to this, like the UNICEF All In campaign. One last thing on adolescence I wanted to comment on, which is the issues of transition. And Rohan, maybe you want to comment on the fact that in some studies it suggests that moving adolescents directly from pediatric care to adult care actually results in very poor outcomes.
Right, and you know, as everyone here knows, it's really in the United States and Europe where we have perinatally infected youth that are now old enough and they're now transitioning to an adult care model, but certainly now soon going to be thousands and millions in Asia and Africa as well. And certainly, as Lynn, as you mentioned, some of the smaller studies, when they actually look, it's quite sobering in terms of these youth are in care on their medications when they're in the pediatric or adolescent clinic, and then within a year or so after they transition to the adult clinic, they're dropping out of care. Their higher mortality rate and whatnot, and I think it's an issue. I think it speaks to a lot of this. It's an important transition period, and if we can, as you're mentioning, with research funding, we're very interested in trying to see how we can improve that transition, because frankly, with the drugs that we have available now, we expect HIV-infected youth to live a normal lifespan. But of course, they're not going to if they stop taking their medicines and are not able to access care.
Exactly. And I think you've given us a nice transition to the next topic I wanted to cover, which is new drugs in kids, which is very good news to have new things presented, dolutegravir and TAF and Maraviroc. And Rohan, I know you're involved in the dolutegravir study. You want to talk a little bit about that?
And in fact, I'm going to just make, because we're talking about the adolescents, I think just a general comment about dolutegravir and TAF and contrast that with, I think another presentation that was made earlier today was on the long-acting injectables. With dolutegravir and TAF, what was really nice is that those studies, when the drug was approved in adults, it was also approved down to the age of 12 right away. And so right away, adolescents had access, and frankly, it was the same dose as adults, and being able to benefit from these drugs that are once a day, seem to have lower toxicity profiles, are much better tolerated. But I think it's a challenge, as we all know, to get those drugs approved down to the lower age groups. The dolutegravir study the data that we're presenting here at the meeting is looking at data now out to 1 year in 6 to 12-year-olds. But as we know, we have to go even lower than that as well with all of these agents. But again, I'll contrast it with a bit of a disappointment that the long-acting drugs, the injectables, currently there's not an adolescent study, and I would hope that the precedent that's been set with dolutegravir and TAF will become much more common. That in fact studies will go down to 10 or 12 years of age right from the beginning, and not in this slow, staggered process.
Right, and not take 7 years to have it approved after it's approved in adults, as that's been true for some drugs. And they saw very good suppression in that study, like almost 75%. So it looks like a very good drug, even for kids who are a little bit younger. And hopefully we'll get down to the more infant age where we really want to start therapy.
And we are, as I mentioned, this is the data for at 1 year for the 6 to 12-year-olds, but we have enrolled 2 to 6-year-olds and soon to be going under 2 as well. So the work is happening, but it goes more slowly than I think we who look after these infants and children would like.
Yeah. And then the study on elbapordetavir and TAF, That's
Yes.
exciting.
That is
Okay.
exciting study. In fact, this study led to the approval of the new formulation of Genvoya, so well known by the brand name, of the single pill for treatment-naive adolescents, as Rohan pointed out, very simultaneously with adult approval, which makes it very encouraging. And the results now are presented at 48 weeks follow-up for safety and efficacy in 50 adolescents, and that looks very, very well. So we are very pleased to see such a good and reassuring results.
Yeah.
And another drug you mentioned, Lynn, is Maraviroc. That is kind of a different end of the treatment. It's treatment experienced children who are already have been faced with quite few medications and actually have demonstrated some resistances. And having a new treatment option of the Maraviroc, which is a CCR5 inhibitor for children 2 years to 18 years of age, and seeing the 48 weeks data of safety, efficacy, and confirmation of the dosing bands that have been proposed is quite reassuring, just to have another drug in arsenal for those who really require advanced treatment options.
Yeah, I mean, I thought that data was a little bit disappointing. I mean, it is highly treatment experienced
Yeah.
kids, but virologic success was about 48%, whereas with the TAF it was over 90%, which is quite amazing.
Right, but TAF was treatment naive
Naive,
patients. This is
yes.
experienced, and in fact, the results of the Maraviroc trial are very similar to the adult data in highly treatment experienced individuals. But you do point out at the barriers and difficulties of treating those who have already experienced possibly
Exactly.
some treatment failure in the past.
But I would add, though, Dr. Aron in his plenary talk this
Yeah.
morning really did highlight that in adults, they are fully anticipating that, from a therapeutic standpoint, that patients with multi-drug resistant HIV will still get viral suppression. And I think we should want for the same thing for our patients. And what
Yes.
it requires is access to these agents that are simpler to take, and less toxicity and very potent. I mean, he said it. It's better drugs that are doing it, and what we want is those drugs for infants, children, and adolescents as well.
And I would add that whenever we hear about this kind of exciting news about new drugs, the second question in my mind is, when can we have that
Yes.
in
Yes.
low and middle income countries,
Right.
particularly in my region in the Asia Pacific, where we have a lot of middle income countries that don't qualify
That's
for some
true.
of the very low pricing. So getting these drugs approved is critical, and then after that, getting generic,
First
lower
step.
cost versions.
Absolutely.
That's how we're going to get it to the millions of children and adolescents who are
That need
living
it.
largely in low and middle income countries in the world.
Particularly with the trend, I think, with WHO, I think will trend towards beginning to recommend dolutegravir potentially as first line for adults. You know, we need to have that data to maybe match it up for kids and also for pregnant women. There were a couple of studies on tenofovir safety. Rohan, you want to comment on that? There was the study that was just in the pediatrics session suggesting that efavirenz-based therapy resulted in better bone mineral density than Kaletra. And then there was another study on tenofovir safety from, I think, the Italian group.
Right, so I think we've known for a long time that tenofovir is associated with thinner bones or lower bone density. We've seen it in children, we've seen it in adults. It seems to be worse when people start treatment, but there do seem to be, as you mentioned, Lynn, I think other factors that may help prevent it, and then additional factors that may make it even worse. And so it does seem like protease inhibitor therapy, when you pair it with tenofovir, may cause more of a drop in bone density. And so the study from South Africa that you mentioned, where they were switched to efavirenz from Kaletra, that they really saw a benefit with the bone density.
But at the same time, it was very sobering to realize that overall children with HIV have decreased bone mineral density.
Yes, that's
And
compared to
compared to
not
non-infected
infected
children,
Yes.
which just highlights how massive and global on the body and the whole organism the impact of disease is, even in the settings of fairly well control in the disease, which I think just highlights the need to really work around the health of these children as a whole.
And I think also needs the TAF drug, which has lesser bone toxicity, because I think losing bone density as a child is much worse than losing
Yes.
it as an adult.
And Annette and I want to, because I know you've been doing bone density studies as well in Thailand, and we've talked about this, that some of it, before when so many children were dying, the thought of, oh, well, they have poor bone, bone loss is not a big deal. But now again, our expectation is that children and youth with HIV will live a normal lifespan, and therefore then this issue of having less bone when they're supposed to be accumulating the most bone does potentially increase the risk for them having troubles when they're later in adulthood.
And in order to do this kind of work, we really need research funding. And we were talking about how in this last pediatric session, so many of these studies were funded directly by the U.S. National Institutes of Health. And if the HIV research budget at NIH is reduced or continues to stay stagnant, it will not be able to support the adolescent studies that are needed on the deprivaring ring or looking at bone health or new drugs.
It's critical because when funding goes down, the first people that lose the funding are
the kids.
Yeah. So I want to end with talking a little bit about the pediatric session that just happened that had some strategy studies. One that I thought was very interesting was the PUSH study that looked at kids who were hospitalized and starting therapy on that day, urgently, within 48 hours, versus waiting until they stabilize and starting treatment at a week. These are newly diagnosed kids. And I think when that study was designed, we all thought starting earlier would be the better thing. Natalia, you want to?
It was very interesting to hear that in this study, and I must say authors did a very nice job designing the study, taking into account comorbidities with diseases like tuberculosis, very common in the region. It was really interesting to see no significant difference in the survival of the children. And this 8 days difference didn't seem to really improve the outcome. There was a really great discussion following, which addressed issues like, was the drug tolerable or tolerated well during these 8 days? Were caregivers' acceptance? What impressed me, besides the results that these 8 days didn't really make a difference, was also very real picture of feasibility of doing something like that in resource-limited settings, which we know can be challenging. But on the other hand, it gives us some time to reassess the family, to prepare them better. Yeah. So I actually see this as encouraging results.
I agree.
To better work and give a little bit time for family and caregivers to settle down and really prepare for uninterrupted long-term ART.
Yeah, I agree. I think the importance of this result is that you have time. Everyone thought if you really need to start those drugs right away. And this suggests that you have time to wait, get the patient stabilized, and then start them on drug. I think the Neverest study was also talked about, Rohan. That was the switching from Kaletra once you're suppressed to efavirenz. You want to comment on that?
Yeah, and I think as we all know, and as we talked about already, the options for infants and the young children are very, very limited. And so right now the first line treatment is Kaletra, which those of us who've tried the liquid version of that is not good. And then potentially has a number of toxicities related to it, and as we know, is now no longer first line for adults. And so we have a first line agent for babies that we're not using in any other age group, which again speaks to the issue we talked about earlier about drug development. But I think what's nice about this study is it is showing then taking advantage of the fact that as children age, there are other options, and being able to switch them over to other drugs, and therefore decrease some of the toxicities, and really that they do very well. And in countries with limited resources, it seems to then align much better with what the older children and adults are taking as well. And so while this study itself didn't deal with that, we all hear about issues with the infant drugs, the running out of a drug supply and stockouts and whatnot. And so I think this strategy of switching them as soon as one can to a regimen that's more in line with what others in the country are on, I think is a
and
really
also
good
appears
one.
Safer in terms of lipid changes. And again, you're talking about young children, and having hypercholesterolemia and high triglycerides is not a good thing to have as a 6-year-old. So I think we've covered a lot of the major pediatric issues. I just want to give a chance for each one of you to see whether you have any other comments to make for our audience on pediatrics.
I think just to bring it back to the issue of adolescence, that there are now these newer initiatives. You had mentioned the UN's All In, there's the PEPFAR Dreams activity. The US National HIV/AIDS Strategy now prioritizes or allows young adults to be a high-risk population. I think that's just the beginning. We need to really see the impact of valuing adolescents and young people at the clinic level.
And I think for, adding on to that is that the adolescent population is a mixed one. What we're seeing is the success of antiretroviral therapy, allowing infants and children now to survive well into adolescence and young adulthood, and as I've said now several times, hoping that they'll live a normal lifespan. But then the other youth that acquire HIV during their adolescence. And so it's a very different type. There's a wide variety of types of youth that are involved, the history that they bring, the context that brings too. And so I think it's not one size fits all for adolescents, and I think even more so with respect to HIV infection.
Yeah, and HIV prevention, because as we see, HIV prevention that works in adults may not work in kids. Nutella.
I know when I will be back to clinic next week, my adolescents are going to ask me what's new. And I know another question they will ask me, when are the injectables coming?
Yes.
So I really want to use this moment to say that we need to really work together, drug developers, regulators, research funders, to move very fast, as we could prove with staff, to move very fast on having the long-acting drugs, injectables, oral, any form they come in, any color they come in, to really have available to the, starting with adolescents and obviously moving to children. So I really think we can grasp on this momentum of really good advancements in adolescent therapy that are presented at this meeting and move them into the pediatric arena.
That's a really good way to end. So thank you very much, everyone, for participating.
Thank you.
Thank you.
Okay.